All right.
All right.
I'm going to tell you when. You ready?
I guess so.
2 minutes.
I should have worn my Lululemon here.
The tush has to be down.
Oh my gosh. All right, starting now.
Go.
Is that down enough?
Tell me about men. Do men have eating disorders?
Men do have eating disorders. You know, if you want to know the statistics on it, right, it's generally considered about a 10-to-1 thing for anorexia and bulimia. But binge eating disorder is probably more sort of equally common in men and women.
Really?
Yep. What more can I tell you? You know, it's probably a different, wow, I'm like feeling the shaking already.
No, let's get your mind off of that.
How many minutes in are we?
Let's get your mind off of that. Let's do a recap. The binge eating disorder is you binge, but you're not...
But you're not compensating with the vomiting or laxatives or the diet pills.
Okay, so... So here's what we're going to talk about.
Yeah.
Your specialty, the types of eating disorders that you deal with.
Yep.
The types of treatment.
Mm-hmm.
The root cause of the disorders, which is I always feel is the biggie.
Yep.
Where does this stem from?
Yep.
And the newest breakthroughs. If there's any new stuff out there.
Yeah.
That we need to know about.
Yeah.
Because there's always new stuff, isn't there?
Yeah. Sometimes it feels like slow going, but we're always trying to come up with a new thing. Yeah.
So, what are eating disorders?
What are eating disorders?
What kind of eating disorders do you deal with?
I mean, I think a lot of us know about kind of the big ones, you know, that come to mind. I mean, really what's on the list, anorexia nervosa, bulimia nervosa. Binge eating disorder is maybe in the list of what's new in eating disorders. Binge eating disorder maybe is one of the most common eating disorders, but until 5 or 6 years ago, it wasn't actually formally acknowledged as a diagnosis.
So those three, anorexia nervosa?
Yeah.
Nervosa. And what was the second one?
Bulimia nervosa.
Bulimia nervosa.
Yeah.
And the third one was what?
Binge eating disorder.
Binge eating disorder. Okay, so, and which ones do you deal with the most?
I see all three. Actually, maybe the most is elements of one or more of these where it doesn't maybe even make a full syndrome, but a woman or a man sort of dabbles in elements of one or more of these things.
They overlap?
There's definitely overlap, yeah.
Interesting. So, okay, so that we have the general specifics of each one. Anorexia nervosa is what exactly?
So anorexia nervosa is basically maintenance of a markedly underweight state kind of due to psychological factors as opposed to a medical condition leading to the markedly underweight state. So if I want to parse that out a little bit more, you know, it's anorexia nervosa is defined by the presence of the underweight state, but also a disturbance in the way one's body shape and weight is experienced.
Gotcha. So this is a person who is very underweight.
Yep.
And it's a psychological issue.
Yeah.
And they are not seeing themselves in reality. Is that correct? So
right.
They may be hypothetically 80 pounds and they see themselves as 200.
Could be like that.
Something.
Or they could even see themselves as 85 or 90 pounds or, or 80 pounds, but maybe not acknowledge how serious that is to be walking around like that.
Right. So do they think that they're overweight still?
Again, there's a range. The classic, I think, anorexia picture that you may or may not know about, or that, as women, I think many of my friends and I know about, as a woman that looks in the mirror, she's very skinny in reality, but she's actually seeing her stomach or her, rear end is massively enlarged, There's probably some of that distortion that some folks struggling with this walk around with, and some folks probably see a slightly more realistic picture rather than sort of seeing themselves as massively overweight. But,
gotcha.
Yeah.
Always goes back to everyone's different.
Yeah, absolutely.
Every patient's a little bit different, right?
Yep.
All right, so bulimia nervosa.
Bulimia nervosa.
Is...
So that's a syndrome of repetitive engagement in binge eating. Can talk a little bit about exactly what a binge is.
Okay.
But the binge eating is coupled with...
So if I had a whole bag of cookies last night,
I wouldn't necessarily call that a binge. I wouldn't necessarily diagnose that as a binge. I'd ask you about things like, did you have intention around that? Were you like, I'm just going to have those cookies? Cause
my intention was to eat the whole bag.
So, did you feel out of control around it? You're like, maybe.
I'm actually lying. I didn't really eat the whole bag of cookies.
I didn't think
I'm just
you
trying
did,
to throw you a curveball.
Yeah.
But I have.
But things
I have.
people feel like they're binging at Thanksgiving dinner, right?
Yeah.
Or feel like they've eaten way too much. But there's a little bit of a culture bound. We're going to sit down and do that. That's what we do.
Yeah.
And some of us do that more than others. Some of us don't take Thanksgiving as an opportunity to.
So this is so binge eating is like an extreme.
So binge eating is eating a much larger amount of food than what might typically be considered appropriate for a meal, with a sense of sort of psychological loss of control around it.
Like you're not thinking, you're just eating.
Kind of almost in a frenzy, maybe. Maybe at a certain point you want to put the brakes on, but it's compulsive. You really can't.
You can't.
Yeah.
And then after that,
you have compensation with bulimia nervosa. So the patient with bulimia, the most typical way of compensating for these binges is self-induced vomiting. But other methods might be used, laxatives to get rid of calories, diet pills. The more diet pills, I take more diet pills because I had a 1,000-calorie binge last night, so I'm going to take 8 diet pills today.
Okay, so diet pills, laxatives, and then self-induced vomiting.
Vomiting, yeah.
Is there one more common than the other, or same kind of like...
Self-induced vomiting
is more common.
Is the most common within bulimia nervosa.
Within that?
Yeah.
Gotcha.
Excessive exercise can also be used as a compensation method in bulimia nervosa.
Gotcha.
And, of course, if you want to talk about what's most common in general for people that, that are interested in compensating for calories, forgetting about a disorder or diagnosis, the mentality of I'm going to go to the gym and exercise is kind of, how people compensate, in their lives in general, right? Or to the extent that one has a mindset of compensating for calories, right?
Yeah, I think
so that's your question is self-induced vomiting is the most common method within a syndrome of bulimia nervosa, but how people compensate for what they eat in general is a broader topic.
So anorexia nervosa, bulimia nervosa, and then there's binge eating disorder.
Right.
So is that I'm assuming that's similar, but it's not quite.
And that's why I say these things overlap a lot, right?
Right. Okay.
So binge eating disorder is basically going to be the repeated binge eating without the compensation.
Without the laxatives.
Diuretics, water pills, vomiting.
Okay, without that.
Yeah.
Okay, that's interesting. So that's clearly different, but there's something common. Obviously, there's the binge eating.
Well, believe it or not, experts with more gray hair than myself, have sat in rooms and debated this, right, for months and years. Is binge eating disorder different from bulimia? Because there is a lot of overlap. The experience of eating a lot of food and losing control around it, there's probably a lot of similarity there. But, we've wondered in the field, do we know enough to sort of say this is a different diagnosis? But that's a question for egg-headed researchers, really,
Yeah, no, that's interesting. Okay. So the types of treatment for these disorders are typically...
It's pretty varied, but, talking to a mental health professional with some orientation to the area is, usually the common theme.
And you are the mental health professional.
I try to be that.
You are.
I am.
You are.
I am. One of them with one, particular way of approaching it, and obviously, the big question is how should we approach these problems? Do we have something that we know is a gold standard treatment to help people out of this?
Let me give you a plug here, okay? So I'm going to cut you off because you are brilliant, you are accomplished, and I've been lucky to have a lot of guests on that have been very caring individuals as well. There's more to just being a women's mental health expert and an eating disorder psychiatrist. Mm-hmm. You are that, but you are, because I know you, you are all heart. Your heart and brains. You care. And that's why you got into this, right?
Absolutely.
Okay.
Absolutely.
So just a little plug there.
Yeah.
I mean, we're not just talking to... Now, this is Dr. Allegra Broft. No, you're a rock star. No,
You're so
You stay
kind.
humble. I'll
Thank
put it on you. So,
Thank you.
are you taking new patients?
Yes.
Okay, we'll get that information out there.
Okay.
And you'd be lucky. Anyone out there would be lucky.
Oh, thanks.
So get in there.
Thanks,
If you need help, get in there. And
I didn't think this part would be a perk of coming to do this today, but
well, you know what? This is about education, empowering, and entertaining. This podcast show, but anyone listening who has potentially one of these three problems, call you.
Yeah.
Call Dr. Allegra Broft. Seriously, this is what you do.
Yeah, I'm here.
Yeah, she's there. She's here. So the treatment is what?
So well, it's interesting thing you say, because I can sit here and tell you what the evidence says are the best treatments that are available. For example, we know, and you could do a quick Google search of eating disorders and find this out probably. Cognitive behavioral therapy is a psychotherapy of tremendous interest within treatment of eating disorders. Is the one that we have the most studies on, right? We have had clinical trials of patients with bulimia undergoing a course of cognitive behavioral therapy, and a fair number of them get at least moderately better. Reduce the frequency of binge episodes, reduce the frequency of purging. We actually know a little bit less about that in anorexia nervosa. But, you also talked about the heart aspect of things, and sometimes I don't know what the secret sauce is of what gets people better, but I think it has to do with, in any therapy, right, making a connection with somebody and helping somebody to feel safe enough so that they can talk about what the root cause is and therefore feel comfortable enough to change it.
Let me chime in here. I'm not an expert in your field, but I know holistic health. What gets them better is talking to someone like you, who is an expert, but someone who has the bedside manner.
Right.
So if I'm across from you,
right,
and you really care about my health, and I know that you care, because you can go to someone and that they're like half in and half out.
Checked out.
And they're checked out, and I'm talking to that person, and they're like writing down notes, and they're thinking about their next patient, and they're like thinking about their vacation.
Right.
That's not going to get them better.
Right.
You're going to get them better because you care, and the patient knows you care.
Right.
And then you get to the root cause, and then you work as a team, right?
Right.
Sort of like a health coach in
right.
a way.
Yeah.
You're guiding them.
Yeah.
But eventually, together, right, you figure it out. So
Right.
you and your patient figure out what the problem is, the root cause, and then get better from there.
Right.
But it's the bedside manner that's enormous.
Definitely.
Enormous.
Definitely.
Okay. That's what separates you.
I hope so.
It does.
I get tripped up with the best of them, It's a tough thing about helping folks with these problems is that you sometimes these disorders can be very severe. Yeah. So sometimes you get to the point where you're working with somebody that is 60% of their ideal body weight, and maybe what deep in your heart is you think the person needs to go to a hospital for a little while, and then it's a conversation about, I think you need to do that. And then, what if you're just in different places that way, but you think it's a matter of the patient's safety,
Sure.
So, I mean, that's just an example that comes to mind, but, often sort of saying what you think the right thing for the person is, you run the risk of possibly alienating them, and that can result in its own
I can imagine
sort of stress.
That's hard. So the cognitive
behavioral
behavior. I told you I mispronounced everything. Cognitive behavioral therapy.
You know what it is. That's the important thing, right?
Cognitive behavioral therapy.
Yeah.
So how does that go?
Kind of what is it?
Yeah, what is it?
So it actually takes a pretty here and now approach to things, which maybe, in some ways, when I say that as a first thing that I say about it, maybe sort of sounds like, well, what about the root? Which is sort of, maybe it goes back to the person's past, or a trauma or a set of expectations they developed about themselves. But we have people do things like self-monitor their eating, so, writing down what they're having for breakfast, lunch, and dinner, but also monitoring, their thoughts and feelings around eating as it comes up. So when a person is sort of on the verge of having a binge episode, what is it they were thinking and feeling in the moments leading up to that?
Okay, so they have to, write it like a diary.
Yeah, so journaling, yeah.
Journaling, okay.
There are some, in the beginning, some here and now types of, modules that we go through, like, okay, alternative behaviors to binge eating and purging, like what can you do in the moment? And this is a lot of common sense, but it's about implementing it in a way with a supportive person around to do so. So what can I do to, help stave off a binge eating episode? Have a thoughtful conversation with a friend or loved one, go do something nice for myself in the interest of self-care. Sometimes food is used as a self-soothing thing for certain types of eating problems. So what can I do to self-soothe that doesn't involve that as an instrument?
Right.
So, so that's a part of it, sort of brainstorming that with the person, which gets you a lot into what is it, that's coming up in a binge episode that, is emotionally needing to be addressed, and how can, and that starts to get to the root, right?
But this is some sort of traumatic experience that these people have had at some point?
Well, yeah, that's probably simplistic, and I sort of use that phrase a little bit, but it's generally, a typical narrative you hear a patient tell you is something like, I was going along okay, and then something happened in my life. I don't know, my parents got divorced, they changed schools, this, that. I felt no longer quite like myself, or, I didn't have my friends around me anymore. All of a sudden, I got sick, I lost 5 pounds, I had a flu or whatever.
Yeah.
My, people at this new school, I'm 14 years old or whatever, noticed, and they gave me positive feedback, and that felt damn good. All of a sudden, I'm like, if I lose a little more weight, maybe I'm on the right track or something. That's solving some problems, right? So it's not a trauma per se, but there will be sort of a series of events, and maybe, at the core, something that makes the person feel a little bit like they're in need of something to help them feel better about themselves in life, or function better, or make the connections that they maybe are missing, or fill a void as far as self-esteem goes, which who knows why that's there. Maybe that's
Isn't that amazing, though, how complex human beings are? That we can have certain situations that kind of like put us up through the moon, and other ones that just kind of take us down. Like even like changing a school.
Yeah.
Like it sounds like so simple. Like, you went from hey, my kids just changed schools. Because I think there's a better school for my sons, and that potentially could affect them.
Be an event, but it's the thing is it's usually no one thing. So it's an event coupled with a person's kind of baseline emotional set of coping. I just said that phrase wrong, but as whatever you have in your insides that you've developed to learn how to cope with change in the world, right?
Right.
So like you said, life is crazy, right? The ups and the downs and all that. Some people with a stable sense of self-esteem experience that in a very stable way, right? Okay, things happen around me externally. I got a D on that test, or I didn't get on the varsity, swim team or whatever. I still feel pretty good about myself. Okay, some people, because of internal psychological structure, will catastrophize that into my life is over now, or
right.
And probably it's the difference between the person that sort of has a stable view of themselves and the person that has a more extreme, unstable view of themselves that's going to be more vulnerable to.
Is that like you're born with a certain constitution? Like how much is it like nature versus nurture?
Well, that's always
we can get into that all day.
$64 million question. Right. It's usually, combination.
All right.
Right.
You ready for your burpees?
Oh, already?
Yeah.
I've just caught my breath from the jumping jacks.
Really? Push-ups?
You tell me. You're the boss here. One-armed push-ups.
What can you do one-armed push-ups?
No.
How about, can you do burpees?
Burpees that's where you stand up and then you kind of burpees yourself out.
That's a bit much.
That's pretty, yeah.
We're going to knock over the podcast table here.
Microphones.
Yeah, that's a little crazy. All right, well, we'll give it a break. We'll do that later. How about plank? How about a plank?
Yeah.
Plank.
How long?
3-minute plank.
We're going to do. Am I going to keep the headphones and microphone on?
I want you to talk about eating disorders, our next subject, while you're doing a 3-minute plank.
All right, this will,
you just called me
I'm
the boss.
Is a journey of trying things you've never done before.
Okay.
So
yeah. I will plank. No, I can't plank. I have to talk.
Yeah, why don't you plank and I don't know, twiddle my thumbs.
This is my show. You plank. I'm telling you what to do. Okay. So I'm putting you on the spot. Mm-hmm. This is like free exercise. So
all right.
Can you do it? Do you think you can do a 3-minute plank?
I probably can do 2.
The tuchus has to be down. I don't want to see. There's no
yeah,
no,
I mean,
no
I
downward
cannot
dog
make
here.
any promises about form.
No downward dog.
You know, my group exercise experiences have probably been
All right,
very
2-minute plank.
permissive, let's say.
2-minute plank.
Mm-hmm.
Can we get
In my wedges or out?
What are wedges?
I'm wearing wedge shoes.
Ow, you kept saying wedges. I'm like, what
Yeah,
the
you're
heck?
like, what is that?
Let me see. The wedges are out.
Yep.
Take them off.
Should I put them in front of the camera?
Oh, I like it.
All right.
How do women walk around in those?
One of those dumb things that we do in the interest
look
of, body image and whatever. Over preoccupation with physical attributes, right?
All right. So 2-minute plank,
Mm-hmm.
and then we're going to talk about. Should we stay on treatment?
I don't know. Why don't you even, maybe you don't even want to tell me what we're going to talk about next. So
Yeah.
it's a real
You got it.
zinger.
All right. Can we get the camera to see her while she's doing the plank?
On that side?
Because otherwise, Because otherwise you're not going to be able to see her.
Okay.
Because she's just going to be under the table on the video. She's going to be.
It's pretty funny that I'm doing that.
Dr. Broft is going to be under the table. You're just going to see me. So let's get the camera.
I want to send a message to all the patients out there, though. That the performance in this
We gotta get
is
this
not
down.
important.
No, it's okay.
No, you know what it is? It's that you're willing to do it.
Mm-hmm.
You're willing to put yourself in an uncomfortable position.
I am, yeah.
And you're giving it your best.
But I'm not doing it until the clock starts.
You got it. But this has to be. Where does this have to be, Christian?
It can stay right there. Just point the big head of it down. It could stay on the table.
Oh, it can stay on the table?
Yeah.
You'll be able to hear her?
Yeah.
Okay.
So that big head part, just face it downward.
I don't know. I'm going to break your equipment here. What the heck's going on? Help me out,
You need
Christian.
assistance?
I do.
You need an adult? There you go.
All right.
Just those legs that are complicated. And now you can...
How's that? Is that good?
Yeah, that should be fine. Let me hear... Yeah, you're good.
All right.
All right.
I'm going to tell you when. You ready?
I guess so.
2 minutes.
I should have worn my Lululemon here.
The tush has to be down.
Oh my gosh. All right, starting now.
Go.
Is that down enough?
Tell me about men. Do men have eating disorders?
Men do have eating disorders. If you want to know the statistics on it, right, it's generally considered about a 10-to-1 thing for anorexia and bulimia. But binge eating disorder is probably more sort of equally common in men and women.
Really?
Yep. What more can I tell you? It's probably a different, wow, I'm like feeling the shaking already.
No, let's get your mind off of that.
How many minutes in are we?
Let's get your mind off of that. Let's do a recap. The binge eating disorder is you
Yeah.
binge, but you're not...
But you're not compensating with the vomiting or the
Okay.
laxatives or the diet pills.
Okay,
Yeah.
so it's 50-50 with men and women
Yep.
when it comes to binging, but no
compensating.
No compensating.
What's the most severe case you've ever seen?
Well, I work on in an eating disorders research program where we provide treatment at no cost on an inpatient level for folks with a range of eating disorders, but including what that means is we sometimes end up seeing the most severe of the most severe. So, we've seen patients at 55% of their ideal body weight, that come in at a body weight of 60 pounds. That, maybe have never weighed above...
Men?
No, women. Oh, I'm
Women.
sorry, you were asking me about severe
Oh,
men.
That was more of a general question.
You know what, guys? I might have to stop the
No. Keep going. You're good. Come on.
Oh, my gosh.
Come on. You're good.
I'm sure my
You-
rear end is not down.
No. You're good. You got 15 seconds.
15?
Yes.
Oh, that's good. Are you going to do a countdown
Actually,
with me?
9.
8,
7,
7,
6.
Well, she's really got more than that. Actually, I'm just
4.
trying. Just
don't
hold on.
start around like that.
Come
Alright,
on.
that's
No.
it.
No. You're almost there.
That
All
was
right.
evil. You psyched her out.
That was 1 minute and 55 seconds.
You know what? I'll take it.
That was good.
That's
Good job.
practically 2.
That's good.
See,
I'm
which,
impressed.
By the way, counting numbers is something that we try to be
What-
non-precise about.
What are
in
you
my
doing
field.
on the floor? You're supposed to be my guest. We're talking about eating disorders. Why are you laying on the floor here?
It's a good question.
Yeah.
Why do I
why does
jump
everyone
through the hoops of like this?
Just because I told you to do it, you didn't have to do it.
Exactly.
But every time I tell someone to do something,
You were that type of bully in high school, weren't you?
I was not a bully. I was not a bully. So that's really okay. So men, 50-50 with binge eating disorder. What about the other ones?
That may not even be quite. It may be like 35, 65.
But it's more prevalent.
It's much more prevalent. Yeah. What about the other ones?
Anorexia nervosa. Any men?
That's more like 10 to 1. Like 10 women.
Legitimately 10 to 1?
Yeah, I mean, there's a more recent study that I think that sort of put the ratio downward to like 7 to 1.
7 to 1.
But yeah, it's in there.
But that's not just men that have the issue and they just don't tell anyone about it.
Well, that's always a question whenever you're trying to, capture prevalence of a disorder, right?
Because I feel like females are always more willing to go
share these
get
things,
help,
right? Yeah.
Right?
Yeah.
And men are just like, nah, I'm good.
Yeah. But I mean, men probably also are not going to get down to this sort of startlingly skeletal physique, that a woman does in this disorder. And men are usually striving more for 4% body fat, and the six-pack abs and that type of thing, right? So if they achieve that, even if they're not markedly underweight, but they might be in a real obsessive mindset about it and really have all the stigmata of a serious problem because it's consuming 90% of their brain space.
So I do intermittent fasting.
Yeah.
Occasionally. Not all the time, but occasionally I do intermittent fasting, which is in the morning I won't eat anything.
Right.
And at night I really won't eat anything.
Your eating is all in like a kind of 8-hour window or something, right?
Intermittent, yeah, like different, spaced out.
Yeah.
So typically, and I don't do it every day, but typically in the morning I'll drink water and maybe a cup of black coffee, no calories, and I won't eat for 4 to 5 hours.
Yeah.
And even today, I didn't eat anything until I had the apples before the podcast.
Right.
And the idea is to give my body a break. And at night, I'll eat, I don't know, throughout the day. And then 7 o'clock, 7:30, 8 o'clock, I'll stop. Mm-hmm. And then that's intermittent fasting. There's different, protocols that you have of it. So do I have an eating disorder?
Does it take up a lot of brain space and prevent you from doing the other activities in your life that would make for you having a fuller, richer life?
You have no idea what takes up my brain space.
I don't. We could probably make that a lot of podcasts.
Yeah. What was the question again? Does it
now
take
who's
up
in charge?
Does it? Does it take
20 burpees for you?
I'll do 20 burpees, but the burpees here, the burpees are hard because I don't want to be banging my head, but I would love to do burpees.
In the other room,
anyway, do you have an eating disorder?
Do I have it? Yeah.
I mean, look, you always,
When can I come in to see you? When are you?
Anytime.
You're taking new patients, right? So when?
Women only. No.
Do I have to come into the city?
Yes, you do.
Okay.
You do.
All right.
Well, a free consult for you anytime.
Free for me?
Yeah.
All right.
And I come to Jersey to provide it.
Right? There you go. But is that seriously?
Yeah,
is that a form of eating disorder?
No, but there is a little bit. Look, like you've said, right? You've said it probably all in the podcast already today. You've definitely said it off the podcast. We've all got to do whatever feels good for us and our bodies. A lot of folks in the eating disorders field would say we don't really know that that's something that does any good, for anybody, right? But at the same time, it's just whatever feels good for you, And like I said, people make all sorts of decisions about their eating, and as long as you're doing it in a way that it doesn't interfere with your life, go for it. Do whatever you want, But if it's, causing you to lose relationships or,
it's causing me to be. It's causing me to be hungry, but not really. It works.
Or even that you would say, okay, if you're walking around hungry or hangry, that term.
Hangry, right? Yeah. Angry and hungry.
To a point you're much more irritable than you might be otherwise. Like, okay, then why do that to yourself? But I wouldn't call you. I wouldn't say you have an eating disorder, but it's always worth thinking about why do we make any of the decisions that we make around food or whatever, right?
Yeah, good point. So, what are the newest breakthroughs? Are there breakthroughs? I mean, we talked about in the beginning. Is there any new stuff?
I mean, I think that the field is a bit slow moving, but I should focus on what is exciting. I tend to think a lot about a colleague of mine's research when asked a question like that. I'm not sure how much it translates into kind of like, I don't know, real world, like kind of excitement, right? But I think it's cool. A colleague of mine has managed to make a research protocol where she looks at how people behave around food in an MRI machine, right? To look at what the brain is signaling or doing. While people look at different pictures of food and make decisions about what would I eat for breakfast that day, what would I eat for lunch that day, what would I eat for a snack that day. And the way she has people making the decisions, the pictures are categorized in with two metrics, right? There's a certain amount of healthiness rating that you as an individual would give that picture, an apple, let's say, and a tastiness rating, right?
Gotcha.
So you have the whole spectrum of pictures, right? Apple, hot fudge sundae, fried chicken, macaroni and cheese, whatever, salad. How healthy do you think that is? How tasty do you think that is?
This person is in the MRI machine.
Yeah.
And where are they seeing the picture? So someone's speaking and saying French fries? Or they're seeing a picture?
No, they're seeing a picture in front of them. Because what you can do in an MRI, it's kind of cool to know. Like you can put on a set of goggles, like virtual reality goggles, and then pictures can be shown to you, and then an MRI can measure how your brain is getting activated, as you look at one.
It's like an advertisement.
Yeah. You can also do things, in a different type of MRI game, right? You could actually do something where, like, push if you see, the arrows going left, push if you see the arrows going right, but you can make all sorts of other
This is cool. I'm glad this is really cool. So she shows pictures of different foods.
Right.
And then there's the brain waves and
Yeah, it's basically an MRI makes a really nice anatomical picture of how the brain looks, but it can also measure things like one of the measures is called a bold signal, which is the ratio of oxygenated hemoglobin to deoxygenated hemoglobin in every part of the brain, right? So an MRI takes slices of the brain, and just as far as making a measure from it, a computer divides it into a pixel, or we call it a voxel, right? But it's one basically a map of voxels that represent each anatomical area of the brain, and then within that you can measure what's the bold signal, so the ratio of oxygenated hemoglobin to deoxygenated hemoglobin. I'm garbling my words a little bit, but basically, if you get hemoglobin is what's in our red blood cells that carry oxygen, right?
Yeah.
And so that ratio of oxygenated to deoxygenated hemoglobin is a measure of like how much is the brain using oxygen and doing work in that particular area. Does that make sense? Okay.
Yeah.
So essentially, long story short, right? You can use MRI to make a measure of how hard is that brain area working, with the caveat that there's obviously a lot of noise in those measures and things like that, right? There's a whole science of, are we really measuring what we think we're measuring by using bold and all of that, right? And it's not even exactly my area of subspecialty within.
When did she or he start this?
7 or 8 years ago, maybe, these general techniques have been around for, 30 years now, something like, a long time, but we're using it more and more across clinical psychiatry these days. It's like the most common method for looking at the brain in psychiatric research, right?
That's wild.
I don't know what that is. But anyway, to get to the nutshell, she's been able to show that, so she's taken persons without eating problems and persons with anorexia nervosa, right? And there's been some interest in the overlap between the neurobiology of anorexia nervosa and the neurobiology of disorders like obsessive-compulsive disorder, for example. And I don't know, that when I first heard about it, I was like, I don't know if that's intuitively obvious to me that there would be any overlap there. But if you think about it, OCD, or obsessive-compulsive disorder, is a disorder of repetitively, making choices, right?
Sure.
I got to wash my hands a million times a day. I got to whatever. Well, our patients with anorexia nervosa say, I've got to repetitively restrict food, or use certain rules in order to make my food choices, right? So the nutshell is, when she had patients making choices, according to, she would have them rate the pictures of the food. How healthy do you think it is? How tasty do you think it is? And then in the third run of the MRI, she would say, now you got to choose a snack for today. I want you to choose which food you would use to make your snack.
Right.
So as you can guess, right, the patients with anorexia nervosa are all choosing the apple, the salad, the whatever, right? The persons without an eating problem will choose an apple. Sometimes, she gives the choice like 100 times, so she can get an average, right?
Right.
But so sometimes the person without an eating disorder is going to choose an apple, but sometimes they're going to choose, the ice cream or whatever,
Right.
But obviously on average, so one of the things that was interesting to document is just, of course, the patients with the anorexia nervosa are going to choose the apple in the salad, 100 times more likely, right? And
100% of the time.
well, 90% of the time or something like that, right? Everybody's got their own idiosyncrasies. Patients with anorexia nervosa have their own, foods that they like the most or whatever. But she showed that an area of the brain involving the caudate nucleus, which is a deep structure in the brain, was kind of getting overused in that decision-making process in the anorexia nervosa patients. So that overlapped with a little bit of what we know about the neurobiology of obsessive-compulsive disorder. So the interesting thing was just that, she's doing work to start to get kind of a neural, it's probably too strong of language to say a neural signature of, but maybe an area that's implicated in the disorder. So that's opening up a whole line of research for her. I'm actually trying to start a protocol that involves sort of a technology called Transcranial magnetic stimulation, which is using a magnetic, an instrument that via magnetic field can create a very low level of electrical current in certain neural pathways in the brain to try to see if we can influence that circuit and then maybe modulate the food choice in anorexia. But that's all very, very new. So not super high likelihood to go anywhere, but we're gonna try.
No, yeah, you got to look at it. So there's basically, I think with a lot of things, some overlap.
Yeah.
Just like these three eating disorders, anorexia nervosa, bulimia nervosa, binge eating disorder, there's some overlap.
Yeah.
So you're saying even OCD potentially
right.
has some overlap
right.
with these other eating disorders.
Right.
Which I think with a lot of disorders, there's always a little bit of overlap, right?
With other things,
ADD, ADHD,
right.
OCD.
Right.
Right,
the
there's
whole alphabet soup, right?
The whole alphabet.
But
there's
yes,
always a little bit of
a little bit of that stuff.
A little bit of something, right?
Anorexia seems to overlap a little bit more with like OCD-like qualities, and actually, what we sometimes see as a patient loses weight, they in anorexia nervosa, we see for the first time they start other non-eating rituals like hand washing, cleanliness stuff that don't have to do with food, almost as a kind of evolving comorbidity of the underweight process, which is sort of an interesting thing. In bulimia nervosa and binge eating disorder, we see a little bit more of the kind of ADHD spectrum, which may map onto the impulsivity component that makes bulimic tendencies like impulsively losing control around food or impulsively deciding to throw up after you eat, kind of goes along with the impulsivity that can be a part of ADD.
Tell me more about your protocol that you just mentioned, that you said you just started working on.
It's still, we haven't even gotten it through the ethics board yet, although we actually just got back our comments and, are probably very close. But,
nice.
That's, what more can I say about it than I already said? Like I said, I have the benefit of my colleague, Dr. Joanna Steinglass, having begun to map out this circuit, and she probably without her encouragement, I don't know if I would be doing this, and another colleague of mine too, but she's eager to see, if there's some validity to this circuit that she's identified through her research actually being something that could be used as a therapeutic target for treatment, right? And simply to just know if there's validity to the fact that this is part of the neurobiology of the illness, right? So if we can use this, so this TMS is a technique that is known to influence neurobiology of the brain. It's actually FDA approved to treat major depressive disorder, so it's not total voodoo science. It's,
So what exactly would you be doing to change the brain? What exactly... how do we change this?
Well, like in this case,
maybe in layman's terms.
Like it is basically, like I said, it really truly is. It's a wand that has a magnetic field that emanates from it, and basically, through I can't get it out in layman's terms. I actually barely understand it well enough myself to do so. But there's a concept of physics that allows for neurons in the brain, right, are all conduct their messages using electricity, right?
Right.
So if you can alter electrical conduction in those neurons in some way, and this magnetic wand, can allow you to do that.
How big's the wand? Do you know?
Yeah, there's different types of it. The one that we're using is going to be a figure 8 coil, and it's, I don't know, it's kind of like two hands. well, we have cameras, I guess, but it's sort of like, it's sort of this long, 6 or 8 inches across.
Do they beat you over the head with it until your brain changes?
You just hold it, and it makes a little clicking noise, but it's...
You hold it where? What part of the head?
That's what you decide based on what neurobiology you think is implicated. So in this case, we're using an area of the prefrontal cortex.
Okay, so which is right here.
Which is kind of towards the front, kind of off to the side. Kind of behind your temples in a way.
Okay, right on both sides.
Yeah.
So
don't try this at home, people.
Yeah, don't. Yeah. No, go to you.
I mean, we're actually, I think, still figuring out exactly. It'd probably be kind of more like in here.
Okay, on both sides.
Yeah.
So the wand, would it be 2 wands or 1 wand?
1 wand.
And they would go and they would touch your scalp.
Yeah. Well, probably hover right above it, I think.
Right above it.
I guess you touch it. Now I took my training course.
In order to, that's unbelievable.
Yeah, and just to tell you, I mean, I realize as I'm talking about this now, it may sound a little bit like voodoo. I don't know how many people have heard of this technique, but like I said, it's FDA approved.
But that's why you're here.
Yeah. It's considered a treatment, not of last resort, but of people that have failed multiple antidepressant trials. At this point, we have good evidence in the
so this is
it's an established treatment, and it's considered sort of an alternative to ECT or electroconvulsive therapy, in that
But this is one of the last lines of treatment.
Yeah. I mean, it's overall it's not extremely invasive, and it's safe. It's much safer than ECT. For example.
Yeah.
So, but it's somewhere in that. Yeah, you're not thinking about that until you've done many of the other conventional treatments. Yeah.
But it's an option.
But it's an option. Again, for depression. So we know almost nothing about applying it to anorexia nervosa. But there have been some small pilot studies done. But just to sort of speak to the fact that it actually is doing something in the brain that you can see. So actually, anytime you do a TMS treatment, you have to establish that you're using the right pulse
and what
that
is it?
creates a current.
What's a TMS treatment?
Transcranial magnetic stimulation is the kind of abbreviation for TMS is transcranial magnetic stimulation. So that's the thing that I'm talking about.
Okay.
Right? So you put the wand over what's known as the motor cortex of the brain, so the area that mediates our movements, right? And you initiate, use of the machine over that area, and you can actually get somebody to twitch their finger by putting the wand over that area, and that's actually how you know that it's working and doing what it's supposed to be doing, because you basically create a little bit of electricity in that area, and that actually generates the movement of the finger.
That's unbelievable.
So that's absolutely,
that's fascinating.
It's doing something to the brain. There's no question, about it. Then you move it over to the area that you think is implicated in whatever the neurobiology of the illness is. So for depression, there's a certain area in the prefrontal cortex that, is thought to be implicated to deeper areas that deal with, that regulate mood, and so you zap there.
But that's great. So it's for depression, but it's also potentially now for these eating disorders, potentially.
And again, like I said, right now we're really trying to develop it just in such a way that we can investigate the neurobiology further to even just see, like, can we make a difference in a person's eating behavior, just in a very, will they make a different choice for their snack for the day? That's all we really want to see. We're very far from thinking that this is some cure or treatment for eating disorders. But you
got to start somewhere.
Got to start somewhere.
Yeah.
Exactly.
So what would you say to my listeners out there who may be struggling with an eating disorder? What would you say to them? What do they need to do in order to get help? What encouragement?
Yeah.
What's the first thing they should do? How do we get them to make a move? Because we need you to make a move. I mean,
It's the important question. I mean, the way I have tended to answer that question, is try to get in to see in the past, right? I still answer it this way: is try to get in and see a therapist or somebody that you can talk to that you feel safe with, to just even get these words out there, just saying what you're doing out loud, it's just giving life to, rather than carrying it all in your head, right?
Get it out.
Get it out there.
Did you finally pay your rent, by the way?
Finally this month.
Because it's been forever since you paid your rent.
How do you know that?
They're ready to kick you out, weren't they? It's a joke. I'm kidding. That's a complete joke. She pays her rent. Where is your office? Seriously.
Upper West Side of Manhattan.
What's the address?
84th and Central Park West.
Okay, Upper West Side. That's a joke. She pays her rent. I'm just busting her
Listen,
chops.
I probably could pay less rent, you know, but
Yeah.
I don't, you know.
Move to Jersey.
Yeah.
That's all right. Then New York's great. New York's great.
Anyway, listen, there are probably many people struggling this way. They don't even, if they can't get access to an eating disorder specialist for whatever reason, see somebody that's not an eating disorder specialist, but just a great person to talk to, you know.
Just a therapist.
That might help. That's better than nothing, right?
Health coach.
Yeah, right?
Just to get it out. So just get it out of your head.
I think so, yeah.
Right?
Mm-hmm.
Just it's like a cup of coffee. You just got to like pour it out. Like the coffee, it's you know, it's, the coffee's overflowing.
You know, it's like sometimes when you say things out loud, it's like, that doesn't sound quite right.
Yeah.
You know, in fact, I've probably had that experience 50 times during this podcast so far. But that's the point.
About 100 for me.
Yeah.
There you go.
There you go. High five.
You did great with that plank. I'm proud of you.
Well, it would have been nice to know if I could have done the whole 2 minutes, but
I'm sorry, I might have screwed you up.
Well, I'll take it. I'll assume that I
155.
could, right?
I'm gonna have you back in, and then I want 3. Then I want 3 minutes. So I'm gonna hold you accountable. To get you to the 3 minutes.
Well, that's another part of what's helpful for some people in therapy, right? You know, is accountability. Although, you know, of course, ultimately, what you're looking for is to develop that accountability within yourself. But it's nice to have a coach to do that. You know, help you do that.
A guide on the side.
Mm-hmm.
It is.
It is.
Support.
Yeah.
To get someone to be there and.
Yeah.
Yeah, I agree.